So in the paucity of time, I ask the first speaker to please come. Dr. Manisha. Hi. Dr. Manisha, Dr. Moshmi, Dr. Raj Hirani. You are Doctor?
Yes, Manisha.
Manish. Okay, fine. Good.
Good evening, everyone. Myself, Dr. Manisha. Today, I will be discuss a case of perpetual surprise and spontaneous resolution. Slides are not.
AV team slides are not moving.
So, a 53-year-old female on wheelchair came to our OPD with complaints of blurring of vision in both eyes. She was known case of spastic paresis with progressive lower limb muscular dystrophy, and the best corrected visual acuity in the right eye was 2 by 60 and in the left eye was 6 by 60. The IOP was 8 millimeter of mercury in both eyes. On slit lamp examination, the right eye findings were within normal limit. The left eye showed diffuse crenulated pigmented keratic precipitates with +2 cells activity in the anterior chamber and posterior subcapsular cataract with retrolental cells and vitritis in the vitreous. On fundus examination of the left eye showed mild disc pallor with peripapillary atrophy, and there was a lesion which was superior to disc, a dull yellow lesion with surrounding retinal edema and with overlying punctate hemorrhages, and there was superior and temporal segmental vasculitis. The right eye also showed mild disc pallor with peripapillary atrophy and healed chorioretinal scar in the periphery. The OCT scan through the lesion superior to disc showed inner retinal hyperreflectivity, thickening and subretinal fluid. So based on this, we assume that the lesion were of infective origin. So we made a presumptive diagnosis of panuveitis suspecting tuberculous etiology. So we advised complete uveitic profile which turned out to be negative. So we put the patient on steroid, but patient was not taking the oral steroids and presented to us 2 weeks later. After 2 weeks, the superior lesion starts fading, but there was appearance of new lesions on nasal to the disc with slightly elevated and marked granularity and perivascular exudates. So we convinced the patient to take the oral steroid, and patient came to us after 2 weeks. So the superior lesion start fading with formation of subretinal vascular membrane, and there was the nasal lesion also start fading with edema and perivascular exudates. The vision was 636 and the KPs and vitritis also in resolving phase. But now patient complains of shadowing around objects. After 4 weeks of taking oral steroids, the media clarity has dramatically improved, but the complaints of shadowing around objects still persist. So patient was concerned and she was not able to visit the higher center. So we took the higher center opinion and there was unusual course of the disease. So we considered the differential diagnosis of primary vitreoretinal lymphoma and tuberculosis. So we planned MRI brain first and then to decide for vitreal biopsy. So both our studies came out to be negative. So in her whole journey, she took steroid only for 2 weeks. So in her subsequent visit, we planned left eye phaco plus IOL implantation. On her last visit, which was post-operative day 7, the superior lesion healed with scar and the nasal lesion also healed with exudation and SRF reduced a lot. There were no KPs, no cells or no vitritis. So my take-home message is that uveitis can present atypically, regular follow-ups are crucial, steroid response varies, and adherence is the key. Rule out systemic causes in atypical, chronic and recurrent cases. Thank you.
Dr. Manisha, is it retinitis or choroiditis? How do you differentiate? Your OCT picture shows diffuse retinitis also.
Sir, there were retinitis and choroiditis both lesions.
So why didn't you think of a viral etiology?
Yes, sir.
Why didn't you think of a viral etiology in the beginning?
Please, a tubercular etiology.
How is it proven tuberculosis? You have a CT scan which has some positivity.
Sir, the reports are negative, but there can be a hypersensitivity reaction to tubercular
So did you give it to the
antigen.
patient?
No, sir. Because, sir, patient, the vision is improving and patient was healing, and we took chest physician opinion,
Okay,
and
so
he also
let me
hold
clear. I
AKT.
just want to elaborate to everybody. If you have TB choroiditis,
Yes, sir.
it's not going to. There is no uveitis which will go away in 6 weeks. It will keep coming back. Then you need immunosuppression for 1 to 2 years.
Yes,
Steroid is just a short term, and you have to give ATT. If there's no 1-2 positive, there's no quantiferon, there's PET scan or a CT scan is not showing. You will not make a diagnosis until you have a PCR. So when you have a retinitis, it is side-threatening. The first diagnosis should be viral, because TB choroiditis is not side-threatening. You can get back vision after some time, but if you overlook a viral retinitis at the first go, you will make a mistake. So you have to get a RT-PCR done of the viral markers. TB can be falsely positive also, but you, at least a CMV, herpes and all need to be ruled out. And you cannot be giving take-home message can't be there that you give twice course of steroids in a patient of uveitis, and then you let it recur. Then you are under-treating the patient. So if you have a posterior uveitis, think of 1 or 2 years of treatment with immunosuppression. Don't think of this short course of steroid. That is outdated now. So you need to give ADT if you think tuberculosis. You have to, then you have a tubercular protein somewhere which is aggravating the uveitis. Then you have to give ATT with it. So let us be very clear that it is a you have to change the concepts of uveitis. You can't think of a uveitis which you treat for 6 weeks, or choroiditis which recurs. If it's a recurrence, the focus trial says you have to give immunosuppression. Okay. So
Okay.
just when you have a uveitis, think of if you have a retinitis, think of a viral etiology first. Do a TAP, CMV, herpes, simplex, varicella is the common ones. Rule them out and then think of giving steroids. Did you do the HIV test, systemic HIV test or something? Did you do any testing?
Yes, sir.
Negative?
Yes, sir. Negative turnout. Negative.
So today, uveitis is moving towards RT-PCR for only these 3 viral markers. Others are clinical diagnosis. And if you ever think of TB, think of giving ATT with immunosuppression for a longer period of time. And always your lesion, if you go back to your slide, can you go back to that slide where you have a OCT?
Slide दिखलाऊं?
Slide खोल लो.
I think Dr. Amit is right.
AV team, can we have the slides again back?
This is for the whatever Amit has said for learning of the postgraduate.
So can we meanwhile ask the next speaker to be ready?
Next speaker to come up. You can review the slide later. There's an article which says there's a UBS Society lecture also. Imaging in you find it on the YouTube. OCT imaging in uveitis. So this is not a picture of a choroiditis. It's more a picture of a retinitis.
So
Okay.
just
So-
look,
so I
look
think
at
look
these
at the picture
Look
now.
at these pictures. Although you don't have a clear-cut OCT, if you have a choroiditis, you will have a choroidal thickening.
Technique.
So the choroidal thickening is missing, and you see a diffuse loss of architecture of the retina. Probably you are looking at retinitis. If you have both, then you are looking at retinochoroiditis. So steroids steroids are not the the right drugs if you are thinking of infective pathology. So you need to understand that in case of infective pathology, you need to treat the patient differently. In cases of what you were talking of, hypersensitivity reaction, you need to treat differently. Anyways, so can
We'll
we go?
discuss later.
Yeah.
So the only retinitis is non-infective is Behçet's. All other retinitis will
good
be
presentation.
infective. Okay.
Good.
Just for your knowledge. Thank you. Nice presentation.
Dr. Mosmi for the next talk, please.
Can I start?
Yeah, sure.
Yeah. Good evening, everyone. So I'll be presenting a case of seronegative acute placoid chorioretinopathy. Basically, I'll discuss on the role of multimodal imaging in diagnosis and management of this case. Okay, so when we speak about acute placoid chorioretinopathy, the thing which comes to our mind is it is characterized by sudden onset, well-demarcated placoid lesions at the level of outer retina, RP and choroid, and mostly affecting the posterior pole. So nowadays, in today's world, whenever we speak about acute placoid chorioretinopathy, the first infective cause which we need to rule out is syphilis. Besides, there are other causes like inflammatory, autoimmune, drug-induced, and paraneoplastic causes also described. So coming to our case, a 28-year-old male presented with sudden onset painless diminution of vision in right eye since 4 days. He was a shopkeeper by occupation. There wasn't any systemic history, and there wasn't even any history of high-risk sexual behavior. The best corrected visual acuity in the right eye was 2/60 with occasional AC cells and retrolental cells. Left eye was within normal limit. Coming to the right eye fundus photography, we could see RP mottling and dull foveal reflex, and one might say there was a yellowish hue also present here, which was a subtle yellowish hue present along the infratemporal arcade. The left eye was within normal limit with preserved foveal reflex. So we did a fundus autofluorescence. I'm sorry for the asymmetry in the pictures, but if we correlate the locations in both the eyes, we could see increased hyperautofluorescence along the infratemporal arcade in the right eye. And besides, there were also multiple discrete hypoautofluorescence dots at the posterior pole in the right eye. So coming to the OCT, we could see there was intact external limiting membrane. However, there was disruption of the ellipsoid zone, thickened and granular hyperreflective RP with nodular elevations, very characteristic of the rosary bead appearance which we talk about. The left eye was within normal limit, and the first thing which came to my mind was whether I was dealing with a patient with acute syphilitic posterior placoid chorioretinopathy. So I got the investigations done, but to my surprise, all came out to be negative. Also, we ordered for PCR, but unfortunately, it was not done. So I couldn't go with an invasive treatment because the results were negative. So I planned to treat the patient with doxycycline 100 mg BD for 28 days. And to my surprise, at 7 days follow-up, there were already a reduction in the thickening of the RP with less granularity, and visual acuity improved to 6/18 at 7-day follow-up. Even if we see the fundus photograph, there was reduction in the dullness of the foveal reflex and the yellowish hue along the infratemporal arcade. But I repeated the TPHA and VDRL under dilution at 3 weeks because I thought probably I'm dealing with an early case of syphilis, but it came out to be negative again. And at 7 days follow-up, even the hyperfluorescence was also reduced. So at 4 weeks follow-up, there was complete resolution with visual acuity of 6/6, and the hyperautofluorescence has completely resolved. Even we did an OCT angiography where we could see a reduction in the vessel density, and there was flow deficits in the right eye, and there was better vessel density in the left eye. So what is unique in my case was, it was the ASPPC-like lesion with repeatedly negative TPH and VDRL, which challenged the classical association with syphilis, and rapid resolution with doxycycline therapy suggested a potential alternative infectious or inflammatory cause, and because of the reduced vessel density, probably there was also an microvascular involvement. Multimodal imaging was crucial because only looking at the fundus photography, it was inconclusive, and it also broadens the differential diagnosis of placoid chorioretinitis. The clinical implication will be, even though serology was negative, repeated testing is crucial, and if required, a double serology test should be performed to avoid false negative results. And in cases where ASPPC-like lesions are present and you are thinking about infectious etiology, a trial of doxycycline may be justified. My take-home message will be, not all ASPPC-like lesions are syphilitic. We need to repeat serology. We should rely on multimodal imaging and also consider alternative infections. Thank you so much.
Thank you.
Thank you. Thank you so much.
We can have the next speaker.
So while we go to the next speaker, the one thing we need to remember that syphilis is a great masquerader. So it can present in a varied kind of, different kind of chororetinitis, retinitis. So always when you are starting steroids in a patient of, uveitis, do a TPHA or a VDRL test to rule out syphilis. Yes, Mr.
Can Sakshi stand by?
Yeah.
So, small eyes, big challenge. Yes, this case challenged both the diagnosis and management, pushing the boundaries of what we know about ocular inflammation in the youngest of patients. Good evening, everyone. I am Dr. Raj Hirani, and let's get on with the presentation. Understanding a bit about occlusive retinopathy or retinitis, it is due to the obstruction of retinal vessels leading to ischemia and vision loss, and can be due to neonatal factors, systemic diseases, or idiopathic causes or infections. The clinical picture that it presents with are retinal hemorrhages, vascular sheathing, cotton wool spots, and neovascularization. So our patient, 11-day-old preterm neonate born at 34 weeks, came to us for a routine ROP screening. He had a turbulent perinatal course: anemia, asphyxia, thrombocytopenia, sepsis, respiratory distress syndrome, which required an NICU admission, oxygen supplementation, and transfusion support. At the initial ROP screening, fundus examination revealed an immature retina with retinal vasculature extended till zone 1. A rather regular ROP visit, but neonates have their own ways of surprising us. But at the 2 weeks of age, the rapid antigen test and anti-SARS-CoV-2 IgG came positive for both mother and baby, and the clinical course took a dramatic turn. By 18 days of life, the retina told a different story with vascular occlusions, perivascular sheathing, and retinal hemorrhages in both the eyes. So this was no ordinary ROP progression. With all the infective workup coming out negative, a systemic inflammatory workup was done, and it revealed sky-high markers like D-dimer, LDH, CRP, and serum ferritin going through the roof. FFA was done in the NICU setting, and it confirmed our worst fears with extensive CNP areas, vessel staining, leakage, and features of bilateral occlusive retinal vasculitis. Hence, a working diagnosis of bilateral occlusive retinal vasculitis secondary to SARS-CoV virus was made. Given the severity of retinal ischemia and inflammatory burden, we initiated IV methylprednisolone at a dose of 1 mg per kg per day, 12 hourly for 7 days, in addition to oral aspirin at 25 mg per day. Intravitreal bevacizumab was also given to deal with the retinal ischemia at 1/3 dose of the adult. At the follow-up examinations, we saw resolving vasculitis, vascular reperfusion, and no vessel leakage was seen at repeated FFA at 7 weeks. Despite the recovery, there was persistent avascular retina for which 532 nanometer laser photocoagulation was done. At the last follow-up, the child had normal age-appropriate vision and no systemic sequelae. So the key takeaways from this case are: this is the first case of post-COVID retinopathy, and ours is the youngest child at the age of 10 days. And the clinical implication is the neonatal hyperinflammatory states can mask as severe ROP, and early suspicion is key. Steroids for inflammation, anti-VEGF for ischemia, and timely laser for avascular retina. This multimodal approach can lead to a sight-saving outcome. Thank you.
And can we have the speaker ready for the next talk here? Any questions, sir?
Can we again go to the fundus photograph where you show that area of vascular leakage that corresponds with the area of vasculitis, because there's a lot of reflection there. Next. सर आपको दिख रहा है ना वो टॉर्च जली जा रही है. So the clinical area of the photograph where you show, okay. So that is one spot you said, no, vascular leakage.
Yes. This was the clinical image.
This is the arrows you have labeled it as vasculitis.
Yeah, perivascular sheathing is seen in the upper
No, that
image.
that is a hemorrhage around the vessel.
Hemorrhage
There's
है
no-
इसके vasculitis ये
So would you call it vasculitis? Actually, there's actually double.
ऊपर वाले में दिखा, ऊपर वाली फोटो में नीचे वो थोड़ा exudation भी है.
exudation other areas you can see the exudations
At angle view.
presence.
So we believe his finding is a mixture of one. So COVID did present a lot of vasculitis. So it's something new for everybody.
ठीक है अनिल.
ठीक,
Thank you,
good.
thank you, thank you,
Thank
Hiran, Raj, Hiran.
So next speaker is Dr. Sakshi.
Good afternoon, everyone. I'll be presenting on anterior uveitis and ankylosing spondylitis, inflammation at the core. How do you forward it? Uveitis is a state of ocular inflammation due to various immunological or non-immune causes, leading to varied complications, cataract being one of the most common. It may be mainly due to uncontrolled or sustained inflammation, but also by prolonged dose of hydrosteroids. The interplay between uveitis and cataract formation can result in blurred vision, increased intraocular pressure, and difficulties in surgical management, making timely intervention and precise treatment crucial. Case details. A 35-year-old male walked to our OPD with cautious gait pattern with multiple joint deformity with chief complaints of intermittent redness, watering and pain in left eye since 1 year and diminution of vision in left eye since 6 months. The intermittent episodes of redness, pain and watering subsided after temporary treatment with topical drops which were not known by the patient. And the diminution of vision was gradual in onset and progressively increasing. In right eye, patient has a history of loss of vision since childhood after trauma with a wooden stick, and the eye was thicycle. There was no history of colored halos, floaters, sticky discharge surgery or any spectacle use, but he had a history of joint pain in large joints of upper and lower limb and back aches since 10 to 15 years. He had history of TB in 2005, for which he took medication for 6 months, and history of poliomyelitis since childhood. There was no history of any systemic illness or any ongoing drugs. The visual acuity in right eye was PL negative because of thicycle. In left eye, it was hand movement close to face, and PLPR accurate in all quadrants. Intraocular pressure was soft in right eye and 42 in left eye. On slit lamp examination, left eye showed fluid normal, there was circumcorneal congestion, there was vascularization superiorly from 11 to 3 o'clock, there were old fine KPs in inferior quadrant, the AC was shallow with peripheral anterior synechiae, there was no cells and flare, and there was iris bombay, it had a seclusive and occlusive pupillae with irregular 3 mm pupil not reacting to light, and there were early cataractous changes in the lens. And the fundus examination showed dull red glow on DDO and 90-degree examination. So we made a provisional diagnosis of left eye chronic uveitis with secondary glaucoma and complicated cataract, probably due to rheumatoid arthritis, which was suspected. On investigation, ESR was high, CRP-RF factor, ASO was negative, and on X-ray, cervical and spine showed bamboo spine on the dorsolumbar vertebra, suggesting ankylosing spondylitis. And hence we did a HLA-B27, which came out to be positive. The B-scan showed right eye phthisis and left eye was within normal limits in the posterior segment. So the target of treatment was for inflammation control, IOP control, cataract extraction, and vision rehabilitation. On medical treatment, we gave anti-glaucoma drugs and topical antibiotics 15 days before surgery, oral steroids and topical steroids 1 week prior to surgery, and we also did a NDI laser iridotomy for better IOP control. We then went to surgical management, which included manual SICS with membrane peeling, anterior and posterior synecholysis, cataract extraction, and hydrophobic IOL implantation in the back. So post-operative, IOP was well controlled at 40 nm Fg after 1 month without any medication. There was inflammation control with nepafinac and topical corticosteroids, which were discontinued 2 months after surgery, and systemic steroid continuing tapering doses as per the rheumatologist's opinion. One of the major successes of the surgery was achieved in terms of good visual rehabilitation of BCVS 618 after 1 month of follow-up, and there was no CME or any other abnormality on OCT. So uniqueness, it was a rare case of chronic uveitis with secondary glaucoma and complicated cataract in a one-eyed patient who presented very late when the vision was PLPR due to associated pain. The patient had multiple joints with bamboo spine on joint pain with bamboo spine on X-rays and HLA-B27 positive, suggesting ankylosing spondylitis. So clinical implication include that complicated cataracts with chronic uveitis difficult to deal with because of number of complications, and post-operative monitoring should also be done to look for complications such as CME or posterior capsular opacification. So the take-home message is patients with poor vision and recurrent symptoms, especially one-eyed, and those predisposed to recurrent chronic inflammation must be paid special attention for better visual rehabilitation and prognosis to improve their quality of life. Thorough systemic evaluation is necessary to know the systemic cause of uveitis and to treat the cause and seek rheumatologist opinion before it is too late. Also, post-op care and follow-up in uveitis is equally important as diagnosis and treatment of the disease. Thank you.
Sakshi, what was the gonioscopy finding?
So there was 360-degree synechiae present and peripheral anterior synechiae.
Would it get controlled with the PI or it would require trap?
It would, first sir, we tried for the PI, but it was uncontrolled, like the IOP was reduced.
The pressure was 14 millimeters without any medication after cataract.
Yeah, before any,
so
without any medication it was.
would open up, or you require trap long term or anti-glaucoma medication long term?
So sir, firstly, as it was 42, we tried first anti-glaucoma medications, like we started only on 2 or 3 drugs, but there was no improvement. The IOP decreased.
The patient is now better. Do you think it will require trap or anti-glaucoma medication long term? Because when you have peripheral, they will keep closing. The inflammation is not going to die down. And do you think in a chronic patient, the flare will ever disappear?
Yes, sir.
So again, I want to highlight that steroids for 6 weeks is not the treatment for chronic uveitis. The patient needs to be on biologics or antimetabolites for life. Is one-eyed. Again, next uveitis will be unsparing. The patient will go blind with glaucoma over a period of time. So do not think that perioperative steroid is just the job. So you didn't start immunosuppression. I am surprised the rheumatologist didn't advise immunosuppression.
Actually, the patient was not even affording for immunosuppression.
No, immunosuppression is the cheapest. Methotrexate is very cheap.
Very cheap.
The patient was lost to follow.
I understand, but if you're presenting a case, you should have written that is the method of treatment.
So ma'am, I think one of the reasons I think that the IOP was 14 millimeters after surgery was that it was a recent, maybe sir, it was a recent onset, because once a PAS once the iris it sticks to the angle, a gonius synechia or a peripheral anterior synechia becomes permanent within 48 to 72 hours, rather even earlier in a case when it's in the case of uveitis. So although it seems a little improbable to digest that the IOP became 14, sir, 14.
Very difficult, one
But
synechia
even if it
forms.
did, so I mean that one reason could be that the angle has opened up and it was the recent onset iris Bombay. Second is that there is now a ciliary body shutdown.
Ciliary body shut down.
So these are two problems. I mean, I want to.
So superior incision SIC is you're looking for a trap later. So don't make a superior incision. Trap would be required. Your gonoscopy says that it's going to close. Patient requires long-term immunosuppression. So these two things one has to remember. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir. Can we have the next speaker, Dr. Silva? She's going to talk on herpes zoster to VKH, diagnostic surprise, unraveled.
Can I start?
Yeah, please.
Good evening, one and all. So my topic is herpes zoster to VKH, diagnostic surprise unraveled. So Vokoyanagi-Harada disease is a bilateral granulomatous panuveitis associated with exudative retinal detachment. Extraocular manifestation of the disease, like dysaceusis and cutaneous changes, occur late in the course of the disease. The exact cause is unknown, but evidence suggests an autoimmune process driven by T lymphocytes against the uveal melanocytes, treated initially with high-dose corticosteroids and then tapered over 3 to 6 month period. And the complications include cataract, glaucoma, etc. Overall prognosis for adequately managed cases is fair, with 60 to 70% retaining vision of 6/12 or better. My case was a 37-year-old male who presented to OPD with chief complaints of redness, pain in left eye, and blisters over left side of forehead for 1 week, uncorrected visual acuity 6/9 in right eye and 6/12 in left eye at presentation. Slit lamp examination revealed left eye herpes zoster stromal keratitis. The patient was treated with oral and topical antivirals, topical steroids, and cycloplegics with significant improvement over 15 days of treatment. 2 weeks later, he returned back to us with similar complaints and was found to have left eye viral keratouveitis. Oral antivirals were continued and topical steroids stepped up. Uncorrected visual acuity in the left eye dropped to 6/18. 10 days later, he comes back with pain and redness, with herpes zoster scleritis setting in. On loss to follow-up, 4 months later, he comes with pain and redness, and this time in both eyes, suggestive of recurrent viral keratouveitis and a normal fundus exam. He was restarted on oral antivirals and topical steroids 6 times a day in both eyes. On 2 weeks follow-up, posterior uveitis develops, and oral prednisolone 40 mg once a day was started with close monitoring. Left eye visual acuity was 620, uncorrected visual acuity was 624 and 612 in right eye. 4 days later, both eye multiple serous retinal detachment was noted on fundus exam. FFA ICGA was advised, and the vision dropped to 5/16 right eye and 6/16 left eye. Diagnosis of probable VKH was made, and HIV, VDRL, tuberculosis, and a history of trauma was ruled out. Injection methylprednisolone 1 gram IV for 3 days resulted in complete resolution of the serous RD and improvement of symptoms. Patient is continued on oral prednisolone 60 mg and prednisolone acetate 1% eye drops in both eyes, which is gradually tapered every 10 days. The FFA shows pinpoint leaks and staining of the disc in the early venous phase. This is a fundus photo that also shows multiple pockets of serous fluid. We did a B scan to rule out posterior scleritis, which we can see a serous RD. This is at presentation with the right eye showing vision of 5/60 and left eye 6/60, where large pockets of subretinal fluid are present, and following treatment with IV methylprednisolone 1 gram for 3 days, complete resolution of the SRF with vision improving to 6/36 in both eyes is noted. So uniqueness in my case is, what we believe is that herpes zoster keratitis could be the possible trigger for VKH in genetically predisposed individuals like this one. However, there is no literary support to the same. The probable diagnosis of VKH was made clinically, as there were no integumentary or CNS findings, confirmed by FFA findings and supported by OCT and B scan. The patient has complete resolution of the serous RD and improvement of symptoms following IV steroids. So clinical implication is that the early detection, aggressive therapy, and slow tapering of steroids and use of immunosuppressants are key to maintaining good visual acuity. Prognosis is dependent on the duration and number of recurrent episodes of inflammation. My take-home message would be timely diagnosis of variable presentations with supporting investigations may be necessary in case of probable VKH disease. In the acute phase, intravenous high-dose steroids are your best friend, followed by high-dose oral steroid tapered gradually over 6 months to reduce risk of ocular complications. Thank you.
So would you give antiviral to this patient long term or would you not? What is your protocol for herpetic keratouveitis? Do you keep the patient on antiviral oral or you just give steroid?
So yes, lifelong in this patient. The patient is currently on.
What dose do you give?
Right now he's on acyclovir 400 mg BD.
So you didn't write that. I think all herpetics should be on long term if you're going to give it.
Yes sir, he's on.
Thank you so much.
Thank you.
So that takes us to the next speaker, Dr. Smriti Rani, Dr. Smriti Rani, for uveal effusion syndrome.
Good afternoon, everyone. I'm going to present a case of uveal effusion syndrome. Uveal effusion syndrome is a grave condition which is thin on the ground. It is characterized by the transfusion of the fluid from the choriocapillaries into the surrounding potential space, causing engorgement and thickening of the choroid and choroidal detachment. It occurs spontaneously and reported in the middle-aged man. Most commonly, it is bilateral, but unilaterality is seen in the old age. A 43-year-old male visited the ophthalmology OPD with a complaint of blurring of vision, more in the left eye in comparison to the right, since 6 months, and which was slowly progressive in nature. No other ophthalmic complaint was elicited. Similar complaint in all the siblings, well in his father since early childhood. Anterior segment examination was normal with sluggish reactive pupil. Best corrected visual acuity of the right eye was 636 and to the left eye was 1/24 with 20 diopter and 22 diopter lens respectively. IOP was normal in both the eye. Corneal dimension was 10 into 10 mm. Keratometry readings shows the steeper cornea. Axial length in the right eye was 13 mm whereas in the left eye was 13.5 mm respectively, suggestive of non-ophthalmos. Fundoscopy revealed the crowded optic disc in both the eye with a macular fold in the right eye and choroidoretinal detachment in the left eye. B-scan showed small eyes with a thickened choroidoretinal complex with a bulge noted in the left eye in the macular area. As you can see in the photograph, there are the crowded optic discs in both the eye, and in the left eye there is a brownish depigmentation which is suggestive of the choroidal detachment, which was further confirmed by the MRI. These are the MRI orbital images, which will show the thickening of the bilateral scleral choroidal complex. As you can see in the image to the left side, thickness is more than 2 mm in the left eye, whereas thickness is more than 1 mm in the right eye. Both eyeballs are smaller in size and contour. Choroidal detachment is noted in the left eye. What is unique in my case, as I stated, it is usually bilateral in the middle age. It is standing out to be unilateral here. This was the first reported case in their family of non-ophthalmos which present as a spontaneous uveal effusion syndrome. Presence of similar complaint in the sibling and his father since early childhood may point out about its familial nature. Clinical implication. Reported case falls in the type 1 non-ophthalmic uveal effusion syndrome. Uveal effusion syndrome follow a relapsing remitting clinical course. Concomitant chronic serous retinal detachment involving the macula can lead to the permanent visual loss. Multimodal imaging can be helpful in confirming the uveal effusion syndrome diagnosis and differentiate it from the other causes of the choroidal effusion. Differential diagnosis may include posterior scleritis, choroidal melanoma, VKH, choroiditis, and central serous retinopathy, etc. Take-home message from my side would be, the presented case emphasizes the value of early detection and keen diagnostic evaluation as it's rarely reported, as delay in the diagnosis of this condition prior to the definitive management may result in the chronic visual compromise. Thank you.
What is the treatment?
So treatment, basically this case, sir, we refer to the higher center. We can start on the medical and surgical treatment both. Medical treatment, though not successful, we can start on the oral, topical or IV steroid.
Surgical treatment.
Surgical treatment will go for sclerotomy.
Sclerotomy. So just one question. What do you want to suggest to the what is the one syndromic association of uveal effusion syndrome that you want to tell the officers?
Uveal syndromic association.
Yeah.
Usually non-ophthalmic eye is associated like spontaneous relapse and remitting course. They will come because sclera is having inbuilt abnormality in the non-ophthalmic eyes.
Okay. So can we go to the next speaker? Thank you. Dr. Soumyadeep Mondal is going to talk on choroidal granuloma. Dr. Datta, please be ready with your presentation as well.
Good afternoon all the teachers. Today I am going to present a case on choroidal granuloma. So ocular tuberculosis primarily affects conjunctiva, cornea, uvea and sclera. In my case, one 35-year-old female presented with sudden onset dimness of vision in the right eye for a week. Her best corrected visual acuity in right eye was 6/36 and left eye was 6/6. Anterior segment findings were unremarkable. Dilated fundoscopy revealed a large choroidal mass 5 into 5 disc diameter in size, temporal to fovea with prominent retinal vascularization and minimal vitritis. OCT macula revealed this mass was choroidal in origin. So certain investigations were called and sputum for AFB was negative, Mantoux test was positive, interferon gamma release assay was positive, chest X-ray PA view showed hilar enlarged opacities, USG whole abdomen was negative for GITB and choroidal tuberculoma was present. So a diagnosis of ocular tuberculosis was made. The patient was referred back to the chest clinic for starting of anti-tubercular drugs. But she came back to our OPD 1 month after her initial presentation and claimed improvement in her vision drastically. Her best corrected visual acuity in right eye was found to be 6/6 and dilated fundoscopy revealed complete clinical resolution of choroidal granuloma. The patient didn't take any anti-tubercular drugs till then. The patient was referred back to the chest clinic and after full course of ETD, there was visible scar formation. So these are the photographs, fundus photo as well as the OCT. On the first photo, we can see this is her initial presentation. Then 1 month after, before taking ATD, there was spontaneous resolution, and then after taking ATD, there was scar formation. So management of ocular tuberculosis typically includes anti-tubercular therapy with corticosteroids. But in our case, the patient was neither started on anti-tubercular drugs or corticosteroids. Still, complete clinical resolution of choroidal granuloma was observed. So choroidal mass, like tuberculoma, can undergo spontaneous resolution with excellent visual recovery. Full course of ATD has to be completed. So my take-home message is any choroidal mass should be evaluated for ocular tuberculosis, and choroidal tuberculoma can undergo spontaneous resolution momentarily. This can mislead any treating ophthalmologist. So full course of ATD has to be completed for preventing recurrence. Thank you.
Dr. Mandal, I think in today's world, getting a biopsy report from a CT scan, you had hyalopharinopathy. So if a CT scan is done and a biopsy is done, you can be very clear whether you have a TB or not. Okay, so whenever we present in a conference, I think we should have more validation of the diagnosis.
Thank you, sir. Thank you.
But you have shown that spontaneous resolution does occur.
Yes, sir.
ठीक है ना? You should read the latest neurophysical relation, new concept. ठीक है ना? There are people are only studying ophthalmology, but not studying other things. There are certain things which can improve the outcome in this infectious disease. Thank you.
Okay, sir. Thank you, sir.
And Dr. Datta, please.
So I'll be presenting a case of sympathetic ophthalmia, grave concern. Sympathetic ophthalmia is a bilateral diffuse granulomatous intraocular inflammation that occurs after surgery or penetrating trauma to one eye in most of the cases. It's usually due to a cell-mediated immune response, which is against the ocular self-antigens found on the photoreceptors, retinal pigment epithelium, and choroidal melanocytes. It occurs usually more so after non-surgical trauma. So we come across a 20-year-old patient who presented with the complaints of dimness of vision in the right eye since the last 7 to 10 days, which was gradually progressive in nature and associated with pain and redness. He had a history of perforating injury to the left eye 2 years back, following which he consulted elsewhere, and he was diagnosed with a superior sclerocorneal tear with iris prolapse along with hypopyon in the left eye. He underwent repair for the same, and he was prescribed oral steroids. However, he had minimal improvement of vision post-surgery, and this again reduced after 1 month. He had no significant comorbidities and no significant drug allergies. As you can see in both eyes, the vision was very poor. There was evidence of anterior segment inflammation. And in the left eye, there were two sutures which were seen superiorly at the site of the previous repair. In both eyes, the media was hazy. The optic disc was hyperemic and margins were blurred, and there was evidence of exudative retinal detachment. As you can see from the USG, there is choroidal thickening as well as exudative retinal detachment. The OCT in the right eye was suggestive of dry fovea, but there was a disorganization of the inner retinal layers, whereas the left eye, there was subretinal fluid present with a choroidal hypertransmission. The fluorescent angiography did show disc leakage. The other details were not very clear due to a hazy view. So we started him on the topical steroids, and he was advised for IVMP 1 gram for 3 consecutive days, followed by a course of oral steroids at the dose of 1 milligram per kg per day, with a weekly tapering by 10 milligram, along with a tablet azathioprine 50 milligram thrice a day for 1 month, with a monthly tapering dose. He was symptomatically better, and the fundus was suggestive of right eye resolved bullous RD, and left eye subretinal fluid still persisted. He was followed up monthly. Eventually, the fundus did show scarring of macula. The vision did improve in the right eye to 6/9, and in the left eye, it was 6/18. So our provisional diagnosis in this case was sympathetic ophthalmia. This was due to the presentation. There was also history of penetrating ocular trauma and presence of bilateral granulomatous panuveitis. So the clinical implication lies in the fact that this needs to be differentiated from VKH. VKH tends to happen more in females, and also there is associated neurological systemic auditory manifestations which take place. Also, it has got a particular prevalence in Hispanics and Japanese. Also, I wanted to note on the importance of enucleation versus evisceration. Evisceration is sometimes more cosmetically acceptable for the patient, although the presence of remnant uveal tissue does predispose to secondary malignancies, which may take place and might itself cause sympathetic ophthalmitis. So the unique feature in my case was that the duration after surgery, it was found to be 2 years, whereas usually we see that 80% of the cases when this is reported, it's usually within 3 months of injury, and 90% within 1 year. So the take-home message was that sympathetic ophthalmitis, usually it's a clinical diagnosis, although we do need ancillary investigations to confirm the same. The mainstay of treatment is usually systemic immunomodulatory therapy, again, IVMP for 3 days followed by oral steroids, and then also we need to add immunomodulators or biologics if needed.
How long you will give the treatment, immunosuppression?
We'll have to maintain it.
How long? Maintenance phase?
Sir, actually, your case wonderfully diagnosed, wonderfully managed. Only issue is that you are tapering your steroids almost like you would be tapering antibiotic steroid eye drops after cataract surgery, 4 weeks, 6 weeks. That is not the way to be. In all these severe autoimmune conditions, you have to give it for at least 1 or 2 years. And you please understand one concept, that you give immunosuppressives. Why? Because as a steroid sparing therapy, all these immunosuppressives will take 2 to 3 months to build up action. Okay. And till that time, you have to give steroids. Right, so for example, you have written that I have given IVMP and then done a 10 milligram taper. So that doesn't build up concept. Your concept has to be that you have to suppress the immunity. So either you give the steroids in immunosuppressive dose, or you start giving non-steroidal immunosuppressants. Non-steroidal immunosuppressants will take up 2 to 3 months to build up the action. So you have to give steroids for at least 3 months. And then once you think that there is no recurrence of disease, you start at the tapering at the rate of 10% therapy per week.
What are the biomarkers you use to see for resolution of VKH? How did you say the VKH resolved? Just the vision? You didn't show any other parameters?
We can do something called the choroidal vascularity.
No. What did you do? How did you know that the patient is in resolution? Did you do OCT? Did you do FA?
Presence of subretinal fluid. Whether the bullous RD is resolving.
So I like to say one biomarker is OCT, right? So did the serous detachment settle?
It settled.
Does FA show subclinical lesions? Did you do a FA? No. Follow-up FA is not there. And you may see of the lesions on ICG but FA. So finally, to be free, either you do an ICG to be free, or you give it for 2 years and then start to think of tapering.
Okay.
So I've been telling everybody, tapering azathioprine at 1 month, tapering steroid in 3 months. You need to say what are the biomarkers. Okay. So biomarker is, one is OCT, second biomarker is FA, and the third biomarker in VKH is ICG, where you have to be negative. Or you can check for choroidal thickening. So choroidal vascularity is not the indication. So whenever you see uveitis, learn about the biomarkers which need to be resolved before you start to taper. Okay, thank you.
Thank you.
I think Neha would be talking about VKH more in detail.
Good afternoon all. Myself Dr. Neha, resident at PCMC's PGI YCMH Pune. Heading to other case, Vogt-Kainagi-Harada syndrome, a reflection on rare case of panuveitis. VKH is a multisystem autoimmune inflammatory syndrome presenting with cutaneous, neurological, auditory and ocular manifestation, usually present in 3rd to 5th decade. Females are more common Females have more common presentation than male. Prevalence in India is noted to 1.4 to 3.5%. The known pathogenesis behind the VKH, the viral infection act as a trigger factor which lead to activation of the immune system against the protein present in the melanocytes, hence leading to activation of the T cells which act against the melanocytes present in the various different tissues, leading to clinical feature of the VKH. Heading toward the case details, a 47 years female presented with blurring of vision in both eyes since 1 month, which was sudden in onset, gradually progressive, associated with pain and redness in the left eye, associated with headache and mild tinnitus. She had similar history in past which resolved on its own. There was no history of trauma or ocular surgery, no history of skin lesions, no history of long-term drug usage, no history of joint pain or no history of systemic illness. On ocular examination, best corrected visual acuity of right eye was 618 and the left eye was 624. Right eye showed old KPs and along with the anterior chamber cell plus cells with nuclear sclerosis grade 1. With left eye, conjunctival congestion was there along with mutton fat KPs with AC cells plus 2 and flare plus 1 with nuclear sclerosis grade 2. Intraocular pressure in right eye on NCT was 18 and right eye and left eye was 25. This is dilated fundus examination. Both right eye media was clear and left eye there was a grade 1 vitritis. Both eyes showing disc edema along with the small multiple yellowish pockets suggestive of subretinal fluid showing the serous retinal detachment. Blood vessels were normal for which the investigations were done. The lab investigations were normal and chest x-ray was done which was within normal limit. The OCT images at first visit, both eyes showed disc edema along with the serous retinal detachment. My patient, 47-year female, having the right eye anterior uveitis with nuclear sclerosis grade 1 with serous retinal detachment. In the left eye, it was panuveitis with nuclear sclerosis grade 2 with serous retinal detachment. Differential diagnosis for my case are Vogt-Kainagi-Harada syndrome, sympathetic ophthalmitis, tuberculosis, central serous retinopathy, and posterior scleritis. On the basis of history, clinical examination and investigation, my case is supposed to be a VKH, for which the treatment was given was the steroid pulse treatment, 1000 milligrams per day for 3 days. Then patient was shifted on the oral steroid tablet prednisolone 1 milligram per kg body weight for 6 months in the tapering dose. During this course, after 2 months, the patient was started on tablet methotrexate 5 mg OD after rheumatological consultation, taking in note the steroid-related complications. And simultaneously, the topical eye drop prednisolone 6 times per day was given along with the tapering dose. And topical eye drop Nepafinac TDS along with the eye drop homatropin 2% BD to relieve the ciliary spasm and prevent the posterior synecdoche formation was given. At 2 months follow-up, the OCT was repeated and we can see there was a resolution of the serous retinal detachment. Along with there was a visual acuity was improved in right eye from 618 to 612 and left eye it was 624 to 618. Hence, according to revised diagnostic criteria of the VKH, our case fulfills the criteria of incomplete VKH. VKH have relatively better prognosis of 60% with visual acuity better than 612. Hence, aggressive high-dose oral steroids for at least.
You can finish it.
Aggressive high-dose steroids has to be given for 6 months. Inadequate dosage or duration may lead to recurrence, and if long-term steroids along with the chronic cases lead to complications like cataract, secondary glaucoma, subretinal fibrosis, optic atrophy. Hence, it requires a multidispensary approach. And take-home message for this case is good clinical suspicion aids in diagnosis of VKH.
Can we have the next speaker?
Next speaker.
So, if you're presenting, I think angiography is essential part of presenting a VKH. So, you can have some other diagnosis coming up if you do not do AFA. So, when you present any uveitis case, do not present only based on OCT. You need to present with FAs. So thank you. Next time you will do better. Thank you so much.
Good evening, teachers. I'll be presenting a case of white dot syndrome. So, multiple evanescent white dot syndrome is a rare ocular condition with an incidence of about 0.45 in 100,000. It is characterized by the sudden appearance of multiple small white lesions in the retinal area. Mutes primarily affects young to middle-aged women. It is often unilateral and associated with symptoms such as visual disturbances, blurred visions, or scotomas. So, in my case, a 22-year-old female presented to the OPD with multiple episodes of diminution of vision associated with pain, redness in the right eye since 3 months. There was no complaints of discharge, photophobia, flashes, double vision, and no previous history of ocular trauma or surgery. History of fatigue, however, was present. No history of joint pain, urinary complaints, or fever. She is nil systemic. Ocular examination. In right eye, the visual acuity was 660 with IOP by rebound tonometer, lid agnexa normal. Conjunctival congestion was seen with iris pigment dispersion on endothelium. 3+ cells and flare was seen in the anterior chamber, and posterior synechiae was seen from 9 to 10 clock hours. The left eye vision was 618 parts with rest of the anterior segment within normal limits with mild anterior chamber reaction. Fundus, the right eye media was clear with a hyperemic disc associated with disc edema and peripapillary edema. Small multiple choroidal lesions suggestive of choroiditis was seen. The left eye media was clear, hyperemic disc edema with peripapillary edema and a macular edema was seen. A macular OCT was done for this patient. Right eye showed mild choroidal elevation and the left eye showed pockets of subretinal fluid. B-scan was done which showed a normal choroidal thickness, and fundus fluorescein angiography revealed early hyperfluorescence. The exact etiology of multiple evanescent white dot syndrome remains uncertain. However, it is thought to involve a viral infection with some studies suggesting a potential link to herpes virus infections. Additionally, there may be an autoimmune component as well. However, in my case, the chest X-ray, serology, HPV viruses were all negative. Clinical examination and imaging resulted in a diagnosis of multiple evanescent white dot syndrome since it was the first episode. The patient was started on a regimen of systemic and topical steroids along with cycloplegics. She is currently symptomatically better and on regular follow-up. However, OCT still was suggestive of choroidal elevation. Differentiating mutes from other retinal disorders is crucial, particularly from conditions like acute posterior multifocal placoid pigment epitheliopathy, since in this condition neurological manifestations are also seen and requires further neuroimaging. It is also important to differentiate it from multifocal choroiditis, as in such cases regular follow-up is mandatory as they can develop choroidal neovascularization. Imaging techniques such as OCT, fundus fluorescein angiography aid in the diagnosis. So take-home message is, it is important to reassure the patient. We have started her on steroids as there was uveitis-like picture, and it is important to keep patient on regular follow-up.
The patient have anterior uveitis also?
No, sir. The picture, posterior synechiae was there, but AC
so normally mutes wouldn't have a anterior synechiae, no? So you wouldn't require steroids. Otherwise, mute is self-limiting. Generally, we do give steroid, but it's so you need to rethink the diagnosis if you are having anterior uveitis with mutes.
Yes, sir.
So more evaluation required for this patient.
Currently, AC reaction is
so if it's still there, you really will have a synechiae and have anterior uveitis. So I think we need to
anterior uveitis is not there.
So you need to relook the diagnosis of mutes. Thank you.
Thank you.
Thank you, everyone. Now I'd like to invite Secretary Dr. Prafulla Morana for the Delhi Ophthalmic Society, who has been instrumental in planning this program for PGs.
So thank you, everyone. So we are running short for the next session. So I'll just say thank you to all the PGs who presented cases today. You all were awesome, and we just crossed the session by 5 minutes. That suggests how good you people were. And you'll be surprised. Today only we covered 112 case presentation overall in this session. So congratulations to all of you. You did great. Thank you so much.
I have seen good confidence in these young people. Good.
I request the speakers for a pictures as well with.
Ayo. Madam.
Praful sir.
The panelists for next session, they may please take over from here.
Ma'am, please join us also. Ma'am.